Thank you, everybody, for joining the Bloodborne Pathogens Training today. My name is Janelle Rios, and I'm a faculty member at the University of Texas Health Science Center at Houston, also called UT Health, and I'm at the School of Public Health. And I am the principal investigator and the director of the Prevention, Preparedness, and Response Consortium. A consortium that is funded in part by the National Institute of Environmental Health Sciences. Before we get started, I'd like to thank Raphael Cohen of the Texas Department of State Health Services here in the regional office that is over Houston Galveston for requesting this training specifically for local health departments and for connecting us with all of you all today. I'd also like to thank our behind-the-scenes folks, Pamela Phillips and Dana Farah, for doing all the wonderful things that they do to get this whole event prepared and webcasted. And finally, my thanks to Dr. Aurora Lay, Subaward Consortium PI at Texas A&M University. She'll introduce herself to you all right now. Thank you, Aurora.
Yes, thank you, Janelle, and thank you all for joining this Friday, although it's not Friday afternoon, so I still have somewhat of your rapt attention. So for this training today, as Janelle mentioned, I'll be going over bloodborne pathogens and regulated medical waste as kind of an initial and refresher training. I am an associate professor at Texas A&M and also one of the faculty directors for the Center of Work for Worker Health. I'm a certified industrial hygienist, certified safety professional, and I've been part of the worker training program for over 10 years. So at this point, I think I've trained about 4,000 workers nationwide. So this ain't my first rodeo. We're going to hold questions until the end. So if you think of a question, you can either type it into the chat or, again, hold it till the end, and I'll field everything then. Great. Just some quick housekeeping for you. So if you need closed captioning on your Zoom panel, you can click the CC button to enable that. You can use Zoom Q&A to ask any questions. I'll give you a link afterwards to complete a webinar survey, and all the registrants will be sending this, will be sent this recording, because obviously you will see a lot of text on the slides. I'm not going to just read off of every single bullet point because that would be very boring, and you can read this on your own. So you will be provided this recording afterward if you would like to revisit the content. So our overview and objectives for this short hour that we're together is to describe the bloodborne pathogen standard. We're going to define what bloodborne pathogens are and other potentially infectious material. We're going to talk about routes of exposure for those BBPs. We're going to recognize some workplace controls that can help reduce those. Describe appropriate exposure response and reporting processes. We're going to talk about spill and cleanup procedures, and then regulated medical waste towards the end. All right, so bloodborne pathogens, or BBP, what is this? These are considered pathogenic microorganisms that are present in human blood or other potentially infectious material, or OPIM, okay, that can cause or disease in humans or infect them. Typically, these are your viruses and bacteria. So when we're thinking about traditional BBP, they're mostly going to focus on hepatitis B, hepatitis C, HIV. You do have your sexually transmitted infections like syphilis, but you also have your vector-borne diseases that are transmitted through things like mosquitoes and ticks like malaria. And then you have your big baddie viruses that cause things like viral hemorrhagic fevers, like Ebola, Marburg, and etc. So essentially, again, anything that can be present in human blood and spread to another is considered a BBP. Now, OSHA, or the Occupational Safety and Health Administration, does have a formal standard, 29 CFR 1910-1030. You don't need to memorize that. But this was essentially established in 1990 because during that time we had well over 200 deaths and 9,000 bloodborne pathogen infections every year. And these are highly, highly preventable. So to try to mitigate some of this, essentially OSHA promulgated this standard. And what this basically says is that employers are responsible to protect workers who are occupationally exposed to blood or OPIM by establishing an exposure control plan and updating it every single year, using universal precautions, identifying things through the hierarchy of controls, which we'll get to in a little bit, to try to protect our workers, offer hepatitis B vaccination, or make it mandatory depending on what field you're in. If somebody is potentially exposed, we're giving them post-exposure evaluation and follow-up. And then for those who are at risk, training them annually. So with the BBP standard, it can be a little squishy in terms of which fields it's applied to. So if you work in a healthcare facility and you're a nurse, you work at a clinic and you're a dentist, you are definitely mandated and covered under BBP. But if you live somewhere like I do, which is in College Station, and I've provided a training for our city utilities department, which deals with our wastewater and garbage, interestingly enough, BBP is not required for them because they're not considered as susceptible to blood and OPIM, even though people throw away all kinds of things in their garbage all the time and trash bags break and accidental exposures happen. But because of the field that they're in, they aren't considered mandated under BBP. So, like I said, it's a little squishy in that regard, but it's always better to be safe than sorry. So that's why you're getting this training today. So in 2001, about a decade after the OSHA standard was promulgated, the Needle Stick Safety and Prevention Act was put into place, and it mandated that OSHA needed to clarify and revise this standard to address the implementation of safer needle devices. So this now includes education and selection of how we reduce sharp injuries, maintenance of a log for accidental needle sticks that occur because we need to document everything. And we must have a written exposure control plan. It just can't be verbal, for example. In the state of Texas, they also have their own version of this, which is under Texas Health and Safety Code 81304. And this is to, again, protect employees and other governmental agency workers from potential BVP exposures. More or less, this is on par to what OSHA has. But we also have to try to prevent contaminated sharp injuries and needle sticks as well. We'll get to that in a little bit. So when we're talking about sources for BBP, of course, you naturally think about bloody fluids. Number one, everybody always thinks about blood, right? But you have everything classified under OPIM as well. So OPIM can also include semen and vaginal secretions, any saliva involved in dental procedures, synovial fluid. So this is the fluid that lubricates your joints in between your bones and your cartilage, whether that's in your knee or your elbow, cerebral spinal fluid, anything that might contain blood, including urine, feces, and vomit. And all bodily fluids in situations where it's almost difficult to differentiate what it is. Also, any unfixed tissues or organs other than skin, meaning if for some reason you get into an accident, right, and a piece of your intestine is coming out of your stomach, and then any human cell line. So this includes those who work in laboratories or might deal with cultures or petri dishes that might have cell lines on them. So the general rule of thumb is that generally, if it's wet and it's coming out of the body, we're going to assume that it's OPIM. And that's kind of the safest way to go about it. The big three infections that we're concerned about with the bloodborne pathogen standard is hepatitis B, hepatitis C, and HIV. So hepatitis B is transmitted via blood and OPIM, primarily through unprotected sex, needle sharing, or vertical transmission, which means the mother is hepatitis B positive, and transfers it to the fetus, which later is born as a baby, and that's through birth. Okay, so most of the time, though, hepatitis B can be short term or long term, but a lot of people are asymptomatic, means they're not showing signs. And like everything else, uh, a lot of these infections can be confused as the flu because you start getting a fever, you get fatigued, you have body joints, you don't feel so good. Generally, people don't realize they have hepatitis until 10, 20, 30 years later after the initial infection because not a lot of people get the characteristic jaundice or yellowing of the eyes. One other signature is very dark, discolored urine. But if you're generally dehydrated or you work in a field where you're outside a lot and you can't drink a lot of water, or you don't have time to take a lot of restroom breaks, so you've acclimated yourself to that, it can be very difficult to distinguish. But the thing with undiagnosed hepatitis, which there's hepatitis is strain A through F, is that if it goes undiagnosed and untreated, it attacks your liver. And your liver is the main organ in your body that detoxifies anything that comes in from infections to exogenous agents. To alcohol, to other drugs. And the liver is incredible. Don't test it out, but if you were to get in a car accident and like the seatbelt sliced off a chunk of your liver, if fully healthy, could regenerate itself within a few months. The cells could regenerate itself. It has amazing detoxification properties. However, the liver can be damaged over time, either through an excess of fatty tissues around it, so like high triglycerides, cirrhosis, which is the scarring of liver tissue over time, either due to excessive drinking or an infection that attacks the liver, like hepatitis. So, if you are somebody that already has abnormal liver tissues or a damaged liver for any reasons, and then you get hepatitis, that can lead to the long term, potentially, again, undiagnosed and untreated hepatocellular carcinoma, which is liver cancer, or end stage liver death. The good news is that hepatitis B and hepatitis A are vaccine preventable. I'll talk about that a little bit more later. Hepatitis C, which has become pretty pervasive in the last decade, is mostly spread through intravenous needle use and sharing or other equipment used to prepare and inject drugs. And that can include nosocomial infections or hospital acquired infections, where we've seen cases where hospital equipment is not properly sanitized. And again, a very similar progression of disease and symptoms. Unfortunate to hepatitis B. Unfortunately, hepatitis C does not have a current treatment for it. There's no or the vaccine is not available. There is a treatment to try to prolong your life and mitigate some of the more dangerous effects, shall you say, if you do get hepatitis C, but it is very expensive. So the medication to treat a hepatitis C infection, if it becomes chronic, without insurance, back in 2016, one pill was about $1,000. So yeah, expensive. HIV has come a long way in terms of treatment and what we know about it. It's primarily spread through, again, blood, OPIM, sexual contact, that vertical transmission again. You can get regularly tested for this almost anywhere, but it does attack the body's immune system. The great news is now that we have a lot of treatments for it, retroviral therapies or ART. There's also prophylaxis drugs now, like PrEP or Truvada, if you think you're at potential exposure due to your activities, right? So there is no cure, but you can live a long, healthy life with treatment. Okay. So, when we're looking at the spectrum of workers that we consider at risk for bloodborne pathogens, pretty low are those who work in offices, call centers, drivers, people who work in medical records, audits, so on. When we're starting to get to the medium level, that's folks who work in housekeeping, first responders, maybe you're a social worker who works with people who are unhoused, dietitians. I even many years ago delivered a bloodborne pathogens training to environmental service workers and custodial workers at Indianapolis International Airport because that was the height of the opioid epidemic and people were doing drugs in the restroom before TSA, throwing it away in the trash cans in the men's and women's restrooms. And there were several accidental needle sticks of custodial staff there. So that prompted the need for a BBP training. And then very high are our laboratory personnel, folks who work in clinical diagnostics, teaching labs, animal care, and then clinical care staff, whether you work at a small facility or a large one. Now, when we're thinking about ways that we can potentially be exposed, our hot zones are where our mucous membranes are, so splashes to the eyes, nose, and mouth. Percutaneous inoculation, of course, accidental misuse of sharps, accidental sharps incidents, exposure to broken or damaged skin. So if you're somebody who has healing scabs or a healing sunburn, you spent too much time on South Padre Island and you didn't put your sunscreen on, okay? Or even if you have eczema or dermatitis of some sort, that is considered a broken or damaged skin barrier that can make you more susceptible to BBP and OPIM. This is not contracted by casual contact, so not by hugging or shaking hands or sneezing, although we should all be covering our sneezes. But the risk of transmission increases with higher titer levels in the source, higher titer levels. So that means for what does that mean to you? That means that if I have, hepatitis B, very high viral load of hepatitis B, and you're an individual who is immunocompromised and has never been vaccinated for any of the things, and I have an open cut and I shake your hand and you also have an open cut and we make direct contact, that is a very high level of the source. Okay. So again, when we think about bio biosafety and infectious diseases in general, I know it drives people crazy because the answer is it depends. It's not easy to quantify, like we can do an exact reading of carbon dioxide levels in the room or even methane levels, because we have to factor in both people's immune systems, their susceptibility to this specific pathogen, and then depending on the infection sometimes and its mode of transmission, whether it's direct contact, only through respiratory droplets or airborne, we also have to take into consideration temperature, humidity, wind speed, all of that. So it can get very complicated. Now, when we're talking about potential percutaneous injuries, there's a NIOSH publication you can click on later when you get the link to this, but we still get tons of needle stick injuries every year, about 600 to 800,000. Most of these go in healthcare settings, but about half of these are unreported. So if we're looking at hospital workers, it's about every 30 needle stick injuries per 100 beds, right? And when I was training a different group, a large waste management company up in Michigan, I said, "Hey guys, do you report your accidental needle sticks and cuts?" And they said, "If I did that, I'd have to stop working several times a day." So they were just not reporting anything to their supervisors. And I was like, "Oh no, this is not good. Let's try to turn this ship around." But a lot of folks don't report these, partially because when you work in some of these industries, some of these injuries seem so commonplace and day to day, people get kind of numb or complacent to it. And it's like, well, nothing's happened before, so nothing's going to happen now. So, you kind of, the abundance of caution gets thrown to the wind. Other half of people don't want to deal with the paperwork. Other half, maybe don't want to deal with the stigma and so on. So, unfortunately, a lot of these do go underreported. We do want you to report it though. And these, again, are highly preventable. So, when we're thinking about prevention measures, we generally try to implement the hierarchy of controls, which I'm guessing many of you have seen, where it is um, an upside down triangle. If you're my undergrad students, they were like, "Is this the food pyramid?" And I said, "No. Look at the look at the words on it." So this is what we use in occupational health to try to prevent injuries if possible. Going top to bottom, most effective to least effective. Elimination, substitution, engineering controls, administrative controls, and then PPE. So if I were to give you a very basic example, right? Where if you wanted to prevent a cut from cutting an onion while you're making French onion soup, okay, elimination would be just not making the French onion soup. Okay, we're not going to deal with potentially getting cut from the onion from doing French onion soup. Okay, a substitution would be rather than buying a whole onion, we've bought a pre-diced onion for 3 times the cost at HEB or wherever have you, Kroger. So now we're substituting out that potential hazard. An engineering control would be rather than us using our knife, if we don't have the best chef chopping skills, maybe we have one of those slap chop things. Maybe you call your partner over to make them do it instead. Maybe you wear cut-proof gloves. Maybe you have a guard on your fingers. Okay. Administrative controls would be to change the way people work. So again, that would be delegating it. And then PPE, the cut-proof gloves would fall under the PPE. So that is the broad overview of a hierarchy of control. So when we're talking about for potential needle sticks, one preventative measure would be an engineering control. And this would be sharps containers, safety sharps, or leak-proof containers. And this is essentially anything that's puncture-proof and plastic. I've seen these sharps containers sold at the pharmacy at Costco for less than $4. Um, After a training with the City of Bloomington, Indiana Parks and Recreation Department, we had such an issue during the height of the opioid epidemic where none of the public restrooms in the park facilities were usable because everybody was throwing needles into the toilet bowls because people would do their recreational drugs in park spaces at night and not have a place to properly dispose of these needles. So after trainings and looking at their exposure plan, the park system installed sharps containers both inside and outside of the public restrooms at all the parks facilities so that people aren't throwing them into the toilet bowls or into the bushes or into the playground where potentially a child could end up getting an accidental needle stick. Another option as well, if you're out and about and you don't have a, a designated biohazard puncture-proof container, is to use an empty Gatorade bottle, an empty 2-liter soda bottle. And of course, do not pick them up with your bare fingers. Try to use something like a grabber, wear gloves, to put them into the container. When we're talking about needle stick safety, most organizations do require medical devices that have that auto retract for essentially needleless systems now. But essentially, we're trying to protect our sharps with safety features, that whole now you see it, now you don't concept. I will say with the increasing popularity of GLP-1s, meaning things like Ozempic or Wegovy or Zepbound, some of them do have those auto-inject immediately retractable needles, but some folks do now self-administer a lot of these injections at home using traditional needles and quite honestly just throw it away in their regular municipal trash, right? So when you're outside of the workplace facility, you may not have this option that has these medical devices that protect from injury. Now, when we're in the workspace, some very common causes of sharps injury is overfilled sharps containers. So you can see here in this photo that this sharps container is too full at this point. So usually sharps containers, you want to swap them out when they're about 2/3 of the way full or 3/4 of the way full. Folks also try to recap needles as well, which should not be done. There's also improper handling. So passing sharps or passing, a vaccine or an injection from personnel one to another, improper suture techniques. You may have uncooperative patients, for example. Perhaps you work in an assisted living facility and you're dealing with a patient who has dementia or is being a little bit uncooperative. You have folks who may not be familiar with the device. So if somebody's having to administer an EpiPen and they're not used to self-sheathing or retractable syringes, improper lighting, fatigue, just being clumsy if you're like me. There's a whole host of reasons why needle sticks and accidental injuries can happen. So the way we can tackle this at the administrative level is training that you're receiving now, vaccinations as well. Like I said, there's vaccinations for hepatitis A, hepatitis B. There's a whole separate 1 hour training that I could give on vaccinations. So we don't have time to go in depth for that, unfortunately, today. I'm happy to do that though, if anybody's interested. I will say that we are in a very different time in the public health space now. I grew up in a different state where I had to receive hepatitis A and B vaccine and proof of vaccination in order to start middle school or junior high. So it's a different space now, right? But if things are vaccine preventable, I am for getting it. All right. And then we also have employee and student health programs that try to educate employees and also students who go to university about this, our exposure control plan, and you have PPE at your disposal, hopefully, right? That can prevent this, especially when we're talking about gloves, or if you work in a setting where you may be exposed to splashes or blood and OPIM, other forms of PPE listed here. So when we're talking about good working practices, again, never try to recap the needle. Never try to recap the needle. Just try to safely dispose of it in a puncture-proof container, even if it is an empty milk jug, and try to use universal or standard precautions. Universal or standard precautions is, again, that assumption that everything that you see out and about, you're just going to assume that it's potentially infectious until otherwise known. Please do not eat, drink, or apply cosmetics or contact lenses in work areas where there's potentially BBP or OPIM. You want to decontaminate all your work surfaces properly, especially if you work in a laboratory setting or anywhere with an autoclave. If you're in a hospital or clinical setting or a setting that requires more austere standard operating procedures, establishing a clean zone versus a dirty zone, disposing of waste properly, labeling things appropriately, and washing hands frequently. We're going to get into those last bullet points more in a jiff. Okay, so the Hep B vaccine series, like I mentioned, I have it. Um, it provides 90 to 95% protection for healthy adults. And if you are at a workspace that where you may be potentially exposed to BVP or OPIM, it's offered at no cost to students and employees with potential exposures. So if you work in a healthcare facility, for sure you're getting this for free. If you are in a situation where the BBP program is voluntary, like I mentioned at City of College Station Utilities program, their safety program was still offering this vaccination at no cost. It is a 3-shot series, so you do have to get it 3 times. Okay, so the second shot will be given 1 month after the first, and then the third shot is 6 months after the first shot. So essentially, after half a year, you'll have all 3 shots done, and this is to build your immunity gradually, right? And so this is reported to provide lifetime immunity. Similarly, other vaccine preventable diseases are measles, mumps, and rubella, or MMR. As you may have noticed in the news, there's been a resurgence of measles. And so, with the first case of death in a child in over a decade being in Texas, there was a little wave here just last year, and I was concerned because I teach at a university with a bunch of grody students. And so I went to my doctor to check my titer levels. And so for measles, it was to have proven immunity, it was like three, a value of 3. And when she pulled my blood, even though I had the MMR vaccine decades ago, it was well into the hundreds. So I was like, okay, I'm good, I'm protected. But that just helped me set my mind at ease. I will say that if you do have a potential BBP or OPIM exposure, the time it takes for a hepatitis or HIV marker to show up in your blood is sometimes 4 to 10 weeks after exposure. So if you have an accidental needle stick and you are very stressed and concerned, and you go to the doctor the next day and you're like, test my blood to make sure I don't have HIV, it's not going to show up in the blood test. It takes about anywhere between 4 to 10 weeks for your immune system to recognize and register it and either mount an immune response to it or present an infection to it, depending on what it is. So that's why it's extremely important for you to report this exposure to your supervisor so that any follow-up appointments and care and diagnostics that you need are covered by your employer and monitored by your employer, because sometimes it can be up to 1 to 2 months after exposure before you can get that definitive answer of whether that potential exposure resulted in anything. I know that's stressful, but again, that's why I feel like reporting is so important, and we'll talk about that more in a bit. Hand hygiene, hand hygiene. I know this seems very fundamental, but 6 years have come and gone since COVID, and we're just reverting to some of our old ways, unfortunately. So some very common methods for contamination is failure to wash our hands. I work in a school of public health and regularly see women walk out of the restroom without washing their hands. I travel frequently. I still mask on the planes. The airport and the airplane is everybody's favorite place to just open mouth cough. That's a whole other subject, though. But washing your hands properly means with soap and water for at least 20 seconds. It's not a quick rub-a-dub-dub. All right. Your phone, if you don't regularly sanitize it, is full of feces particles on it and other items. It's one of the most contaminated things that you probably touch regularly every day, or your computer. If you work in a laboratory or a clinic and you wear your gloves outside of the clinic for any reason, that can also spread contaminants elsewhere. Touching elevator buttons, doors, handles, etc., and so on. The world is ripe for exposure, and you don't know what one person's hand hygiene is like versus yours, and you don't know how many other people have touched that elevator button or that door handle or that keyboard or that whatever before you. So again, failure to wash hands before touching any of your exposure zones or putting food in your mouth is a possible avenue for contamination. One thing that's become very popular are alcohol-based hand sanitizers. For it to be properly effective, it needs to be at least 62% isopropyl alcohol. This should only be used as an alternative, not a substitute for hand washing. So when you do have visible dirt, grime, and blood on your hands, soap and water is the preference. Another thing to keep in mind is all cleaners, all sanitizers, all wipes, all detergents have expiration dates, including hand sanitizers. So especially if you have a little Bath and Body Works hand sanitizer, or you keep a little one in your car, the minute you open that seal and you expose it to the Texas sun and humidity, the chemical components in it are already breaking down significantly. So within a course of a week, a month, that concentration of alcohol has dropped significantly from 62% to some much smaller percent. And at some point, you're just going to be rubbing weird water on your hands. And when you're using alcohol-based hand sanitizers, you should also be applying it to your hands for the same duration you would as hand washing, which is a minimum of 20 seconds. Outside of people who work in this space, I have never seen anyone in the general public using hand sanitizer and rubbing their hands thoroughly for more than 20 seconds. But that's something to keep in mind if you are using these alcohol-based hand sanitizers. Now, if you were to come up with a potential exposure plan, one example here, you can see what UT Health has. They have several hotlines to seek medical attention, one for employees and one for students, right? So if you have a needle stick exposure or a glass exposure or cut exposure, you want to immediately apply first aid by cleaning that site of injury and flushing it with soap and warm water for at least 15 minutes. 15 minutes, 15 minutes. Okay. And that includes eye wash stations with your eyeballs. I know that seems like an extremely long period of time, but you have to flush it out in order to prevent it from spreading further, especially if it enters something like your eyes, where your eyeball rotates constantly in your skull. And so there is a former colleague that I knew that was a safety professional for many years in Indiana, had an individual that did end up using an eye wash station after um, an exposure to a chemical, but he did not flush out his eye for more than 15 minutes, and only did it for 5 minutes. And with the rotation of the eyeball and not flushing all the eye properly, that individual ended up getting a chemical burn at the back of his eyeball that affected his optic nerve. And so he ended up going blind in one eye just because, again, it was not flushed for the length of duration of time. If there is no soap and water available for you to do that, you can use an antiseptic or a saline. But again, flushing for that extended period of time is highly recommended. Immediately after that first aid is administered, you need to contact your supervisor and let them know. And this can help, again, with trends. If everybody's getting needle sticks at work, we've got bigger problems. This can help with any follow-up appointments you need and coverage of that. And then worst comes to worst, if any workers' compensation claims need to be filed, or if you, for some reason, in an absolute worst case scenario, end up getting exposed to this disease, which now becomes chronic and you need lifelong care for it, there is documentation and coverage which should be supplied by the employer. So again, we need to evaluate how much our employees are potentially exposed by duration and frequency, implement various exposure control methods, and then we need to report. Okay, if you are one of these organizations where BBP is mandatory, you do have to report that to OSHA annually under the OSHA 300 logs, which I can address questions about that more if people have that later. So when we're creating our exposure determinations, you need to look at all job classifications, all job classifications. So that means that if somebody is a certified nursing assistant versus a registered nurse in this wing versus that wing, if somebody is an office worker in IT versus if somebody works at the front desk at a county health department where they do have a vaccination clinic, those are different job classifications. So we need to identify the job classifications where employees have occupational exposures, and then list tasks and procedures that may be potentially dangerous or expose them to BBP and OPIM. And from there, again, we need to implement our plan of all of the following that I've already discussed. And if we are having to follow up with employees, letting them know that it is confidential medical evaluation and follow up. So, absolutely, under no circumstance, after an employee has a BBP exposure, should you put them on blast. For example, if I worked at a warehouse, uh, and I was colleagues with Janelle, and at our daily safety huddle the next day was like, hey, Janelle got exposed to hepatitis B. That is absolutely breaching confidentiality and should not happen. But you can de-identify and anonymize the information that you're hopefully record keeping and look at the data and say, okay, for an office, we've had 4 workers with accidental needle stick exposures. That seems kind of high, and we know who they are. Again, confidential. And so, how are we going to prevent this from happening in the future? So, if a worker is potentially exposed, you should coordinate with a clinic of some sort to have a healthcare provider provide their treatment. Baseline tests that are available are for all the bloodborne pathogens and potential sexually transmitted infections. And working with the healthcare providers in place, they will give you the proper course of action for treatment and post exposure prophylaxis, meaning what can we do now that you've had it? What can we do to mitigate it, monitor it, treat it? Um, there's new guidance for HIV that has been put in place as of last year that you can look at the STACS website in particular for HIV if you're interested. Now that we have such a wealth of knowledge and research and ways to address pre and post exposure of HIV. And it's important for you to know your rights. So you are entitled to a confidential medical evaluation and follow up, HIPAA, okay, documentation of the routes of exposure, and counseling and evaluation of the reported illness. You're entitled to all of this under your employer. You should not be paying for this out of your pocket. The only reason you would be paying for it out of your pocket was if you didn't report it to your employer and then you're trying to handle it on your own, which is highly not recommended. And when we're looking at transmission risk, again, for HIV, it is pretty low, but percutaneous injuries and transmission of HIV or hepatitis, like I said, hepatitis B or C or any hepatitis can be pretty debilitating for the health of your liver. So not getting it addressed may come back to haunt you 20, 30 years from now. Okay. Now, okay, I know I only have a couple minutes left, so we're going to try to get through these slides. If we see potentially infectious materials, we should try to clean this up using EPA registered disinfectants, a 1 to 10 bleach ratio. We're wearing proper PPE. We should look at the disinfectant, whether it's bleach or quaternary ammonia, and making sure we're following the instructions for contact time for disinfection, 10 to 15 minutes or per directions. And you should not be using reusable materials, disposable paper towels. Once everything is cleaned up, put in biohazard bags, which are those red bags there. This is all regulated medical waste. You can see the list there as everything that's considered regular medical waste or Class B waste. Often these are put in biohazard bags, but if you work in an office, you don't have the luxury of having these biohazard bags because that means that you have a separate waste handler outside of Republic Services, City of Houston, whomever that would be collecting this waste separately. So in the case that you don't have a separate regulated medical waste stream, just please try to bag it inside of another bag, like double bagging before you put it with the regular waste stream. And know when to throw it away, right? If you do have regulated medical waste, you're putting it in the biohazard bag. But again, we do want to try to avoid mixing things together like sharps, hazardous materials, medications, diapers with our regular compostable garbage. Try. Okay. This also regulated medical waste. We can get more into detail if you want to email me about this. Not all of you work with an autoclave, and not all of you package regulated medical waste on a regular basis, but this would be the proper procedures to package and then get this either picked up or de-sterilized. When we're talking about sharps, again, you can buy one of these containers at Walgreens, CVS, HEB behind the counter. At Costco, like I said, it's less than $4. I look every time to see what they got going on back there. Or in a pinch, puncture-proof plastic container. So try to dispose of sharps in that way so that they're not, again, mixing around in the garbage bag, ready to stab someone accidentally in the leg if they're taking out the garbage. And okay, lastly, just some pictures of poor practices. So I know this looks like some kind of horror story. It's actually pretty common, where you look in storage facilities and there's just boxes of PPE and different laboratory materials stacked up on one another. And you can have sometimes loose sharps placed on top of bench tops, loose sharps placed at the very top of waste bins, or things that are improperly stored. These are poor practices that we want to avoid. And again, improper disposal is a risk to custodial workers, waste handlers, park services, utilities, and so on. So I would say we all, I think, are trying to be good stewards of the environment and our workplace environment. So again, trying our best to prevent accidental needle sticks, cleaning up bloodborne pathogens or OPIM when we see them, or assuming that it's going to be OPIM and disinfecting of it properly, taking an abundance of precautions. And that is the long and short of it. I know I went very, very fast for a lot of material. Before I to pass it over to Janelle to see what questions came up, I do want to point your attention to two things. First is an evaluation. You can scan this QR code with your phone, and in less than 3 minutes, you can evaluate how I did on this training. That's me, Aurora. The provider was Texas A&M. And the second is that if you would like to receive a certificate of completion for this training, you're going to go to this tiny URL here, which is go.uth.edu/P2R underscore BBP certificate. And that will get you the information to request your certificate of completion. So with that, all right, Janelle, what questions came up?
That was great. Thank you so much, Dr. Lay. I should call you Dr. Lay. We know each other we're very
You can
familiar
call
with
me
each other,
Aurora. It's
so
fine.
we're very informal around here. So thank you very much for that. Can you remind everybody what OPIM stands for?
Other potentially infectious material. So that's basically anything that's not blood. And if you're walking on the sidewalk and someone hocked a loogie, that's OPIM. If you're walking past the stadium after UT and A&M played and you see some barf, that's OPIM. If you see some waste and you're not sure if that was a human or an animal, that's OPIM.
Very good. Thank you. The next question is about exposure reporting, and I'm not sure if the questioner was asking about if it's a regulatory requirement or if it's just a suggested requirement. And you're the perfect person to answer this question because of your research at nail salons. Would
Yes.
would accidental cuts from dirty or unsanitized nail clippers also count? Had a case, so I think this person is a physician or a healthcare provider, had a case a while back where the newly acute HPV patient said the only thing she did recently was go to a nail salon where they didn't clean the equipment and they cut her finger.
Okay, that is a little bit different. I know I have a whole other life, you guys, where I do occupational research, and nail salons is one of them. So, um, if you're talking about the workspace where you where you do have that mandatory mandated BBP program, like a healthcare facility, like a hospital, MD Anderson, Baylor Scott and White, you absolutely need to report any accidental cut, needle stick exposure. If you're in one of these voluntary programs, like a utilities department or municipal waste, and you get this accidental exposure at work, you also need to report it. Okay. Now, this sounds like a situation where this person's receiving secondhand information about a patient who went as a client to a nail salon. Now, if the person suspects that the nail salon isn't sanitizing the materials, which they all should be using autoclave or sterilization techniques, the recourse for that would be reporting the nail salon to the local county health department, which provides inspections and licensure for that nail salon. So that nail salon would unfortunately then get a visit from the health inspector, who would then go through and be like, hey, what's up? You're just using dirty equipment or what? If they're Because they were a consumer or customer, technically, no live skin should be cut in the process of a pedicure or manicure, although it does accidentally happen, right? So, because they were not an employee, their only recourse would then to be to report it to the local county health department, and see if they can get the county health department to investigate this business and then get exposure monitoring that way. But because it did not happen to them as an employee, the responsibility of who would pay for the diagnostic blood testing and subsequent follow-up exposure, that is a little fuzzy and may fall on the consumer or on the business, but that very seems like a small claims court situation. So that's not as clear. But if it was a situation where, like, a nail salon worker accidentally cut themselves in the process of doing their job, they would report it to their supervisor immediately, and that would be covered under BBP.
Great. Thank
Hopefully
you.
that answers the question.
I don't see a follow-up with that, so I think it did.
Okay.
Great. And you were talking about exposures, especially in public bathrooms. That prompted this question, it appears. What if you are at a public bathroom and someone touches the door and did not wash their hands? Now, I think all of us have seen that happen.
Yeah.
Yes, and it just appalls me when I see it. It's like, so perhaps some suggestions. I started to type out an answer, but it's probably to come from you on the
Ye-
air.
Yeah, I mean, everybody has different tolerance levels for these kinds of things. So I know some people that are very much in the mentality like, "Write some dirt in it. Let's expose me to all the things to boost my immune system." But I will say, when given the choice, especially in public restroom facilities, if there's paper towels and hand dryers, I am a very eco-friendly person, to the extent where I drop off my old batteries at Batteries Plus, and I, dispose of my old clothes at a textile shredding bin. One thing I never compromise on is paper towels versus hand dryers. I do not use hand dryers. Those are cesspools for germs. And a lot of times, specific ones like that rhymes with Schmeischen Airblade, the intake for the hand drying is the same as the exhaust. So it's sucking in dirty germ water and spewing it out, as essentially a respiratory cloud within a certain foot radius. So if you have the option to use paper towels to dry your hands, absolutely do that. And on the way out, I don't throw my paper towel away in the garbage can. I hold on to it and use that to open the door if there is not a toe pull, or if it's not a door that simply pushes open. At my workplace, I bring the paper towels with me and use that to open the door, and then throw the paper towel out either in the garbage can that I see along the way in the hallway, or just throw it away in my office. Sometimes If I'm in a pinch and it's unfortunately a bathroom where there's only a hand dryer, I might use the sleeve of my jacket if it's available to me, or I'm wearing a long skirt right now, so I might just use the end of my skirt because the probability of me touching the end of my skirt and rubbing up on it again when I'm potentially doing this or this is way less likely than using my hands directly. So I would say that, or if you feel like you absolutely have no other choice, use hand hygiene, just open the door. And usually outside of the door, there's a hand sanitizer dispenser that's a holdover from COVID. Sometimes there's stuff in there, sometimes it's empty. I always carry one on my person and then apply hand sanitizer gel for 20 seconds.
That was perfect. That's exactly how I would have answered that as well. Well, and that is all the questions we have, which is perfect timing. We have
Okay.
4 minutes left in case there's any last minute questions, or if Aurora, there's anything you'd like to expand on during this
I,
time.
I would say people get really shy and feel like sometimes there's silly things or whatever. So you can always email me. You can say you attended the session today. If you want to discuss further about regulated medical waste and type B waste, I'm happy to do that. If you want more information about the safety and efficacy of vaccines, I'm happy to do that. You could Google me and pull up my email, or my email is just simply able, at tamu.edu. And then lastly, please do fill out this evaluation and then go to the link if you need your BBP certificate. But otherwise, thank you for spending your Friday with me, and hopefully I got you thinking about some things, or for those that are at the head of their agencies thinking about modifying or updated their exposure control plans.
One more quick question. Is blood that is purchased from a trusted vendor for forensic coursework still considered BBP?
No, not for forensic coursework.
Great. All right. Well, that is all the time we have. Thank you so much, Dr. Lay and Pam and Dana and Raphael Cohen. Thank you all, and stay tuned for future courses that we're going to have. We will be in touch. Thank you
Okay,
all.
thank you. Signing off. Happy
Bye.
Friday.
Thank